just diet and physical activity? What percentage of obesity can we attribute to biological factors, with the remaining percentage influenced by environmental factors? You have three options. The three answer options may vary slightly according to your location, so please choose the one you think is the best. And after we've heard the presentations, we will go through that polling question once more. Thank you. So, Andrew, if I may start with you. You've kindly introduced yourself. You told us a bit about yourself. What I would really like to know, and I think that the audience would love to know, is your weight loss journey. So, can you please explain what type of interventions you've been through, and have you tried seeking support? How did that work for you? So take us through your patient journey, please.
Absolutely. So
Thank you.
My patient journey has been going on for most of my life, especially my adult life in particular. My main journey out with the kind of normal kind of diets and weight loss initiatives that are out there was through my own general practice, my general GP. When I went to see her, it was about a completely unrelated issue. It was nothing to do with my weight at all. It was something that was completely unrelated. It wasn't until the end of that consultation where she brought up my weight issue. The important thing to say is that she asked before she started discussing it, which I think is really important.
So she asked you whether she could discuss
Absolutely.
your weight with you, which is a great
Yeah,
positive thing.
Seeing the kind of same primary care for as long as I can remember, we have built up a relationship where she knew that something wasn't quite right, and she was just trying to get to the bottom of it.
Mm-hmm.
So following from that consultation, I was referred to the weight management service for my area. Part of that weight management service, I had to go through an initial assessment to see if I would qualify for the service that was there.
Yes.
It would also determine which pathway I would go down from that service. If it was a standard pathway that I would go down, or if it was a psychological pathway. The psychological pathway deals more of the kind of emotional eating side of things, eating disorders, both of which I was kind of falling foul to. It was the binge eating, the secret eating.
Was that something you knew before going to that service, or was that something you found out through the assessment you had?
I knew that it was happening because of the environments that I was in. I knew that I was secret eating. I knew that I was hiding things from people, and emotional eating as well was part of that. So following on from that initial assessment, I was admitted into the service. Went down a psychological route first of all. So it was group sessions that were held. It was no more than 12 people that were in a group. That was quite daunting at first, having to kind of open up to people that you don't know. But it did become very apparent that all these people that were sitting in the room were very similar, if not the same, and they were on the exact same journey as what you were. So that allowed you to kind of open up, share experiences, build bonds and friendships, which wouldn't have been created as a result. That would last probably about 6 months to a year that you were in that sessions, the kind of monthly, weekly sessions that you would go to. It then went down more of a kind of medication route. They were going back 12 years now. So the various different pharmaceuticals that were available at the time were very limited. So again, it was only a 6-month period that you would be on what was there. They would then move you on to an extremely low calorie diet to see how you got on with that before eventually then being assessed and referred for weight loss surgery.
Okay.
So the whole process from start to finish just of that lasts at least 2 years whilst you go through each of the different assessments. That's not to mention the kind of wait to get on to the initial consultation to begin with, or from that initial consultation when you start the groups from there.
May I interrupt you for 1 second, please? Can we take one step back? So before you went through all of that specialist assessment, how many self-directed interventions, how many self-directed diet plans, what did you try before you actually
countless amounts. It was the kind of high street type diets that you have that are out there. It was the low calorie eating. Anything that was available, I would try. It may work for a short time where you would lose a little bit of weight as a result of that, but you would end up regaining that weight that you'd lost,
Maybe in some
plus
more.
a wee bit
Yes.
more than what you had lost to kind of begin with. So it was very much like the kind of saying that's out there about a yo-yo kind of
Yeah.
diet that I was on. That was very much lose, then put back on.
Thank you. And please continue with the surgical pathway. You mentioned the surgical pathway. And did you have psychological support after surgery or
Yes.
only before surgery? You continue to have.
So continue to have that
Okay,
after
that's very important.
surgery. So the service that I was on recognised that when you emotional eat in particular, after surgery, you're not going to have that support anymore because it's gone. You physically can't do it anymore. So I was lucky enough to continue with that psychological support afterwards to help manage those issues that may arise, to come up with coping mechanisms where normally I would turn to food. There was other kind of psychological methods that could be used to support through that process.
Thank you. And do you remember, or were you told if there were any concerns by the team because of what you report as binge eating, emotional eating? Emotional eating, maybe not that much, but binge eating, was that a concern before surgery? And could that jeopardize your treatment?
Yes, it could. So the whole process that you go through was very much to get that under control. So that's what the psychological support focused in on, and it came up with techniques that you could use to move away from that. So it was the emotional techniques that you could implement to move away from the pull towards the food that you're binging and the triggers that are there. Yeah.
So overall, you would say it was a helpful and productive process for you?
Absolutely, yes. Yeah. I don't think I could have went through the process without it.
Thank you. Okay, so you've had a very positive experience, it sounds, from your primary care physician, which is not always possible. It's not because of the primary care physician's fault. It's because of the system and the rhythm. So can you share other positive experiences from your weight loss journey or treatment journey, I will call it, and any negative experiences with healthcare professionals that resonated with you and you still remember? So the positives and the negatives, if any.
Yeah, so there's plenty of both. The kind of positives was the process that I went through very much set me up for success following the kind of post surgery type route that was there. After surgery, I was moved on to the pathway for people who had bariatric surgery. That support was, again, a mixture of group sessions where you'd be in with people who had the exact same procedure as what you had. You would go through other areas as well. So there was one-to-one sessions too, where you would speak with a dietitian and you would look at your diet and how you were kind of coping with that. The issue that I had was that only lasted for a 2-year period. After that 2-year period for myself, it was almost as if that accountability had gone. I was not being held account by anybody anymore. And that's where I found that issues started to creep in, that the kind of regain started to come in as well. At the time, not knowing what I kind of know now about obesity, that was very much me. That was my fault. I had failed at what I was doing.
I wouldn't say that. I wouldn't say it is your fault. That's very helpful, and we really appreciate your insights. So you mentioned also pharmacotherapy. So I would like to know everything around your entire journey, with different interventions. You spoke about the self-directed interventions. You spoke about surgery. Can you tell us about your journey with pharmacotherapy?
Absolutely. So following the weight loss surgery, I was classed as a success from the service that I was in, losing over 100 kilos at the time. And it wasn't until obviously after I was discharged from the service.
When was that? How long after the surgery?
So 2 years after the surgery.
So you had continued support, including dietetic, surgical, and psychological support for up to 2 years.
Up to 2 years. Yeah, that's correct. So everything was going fine from there. We then came up to COVID and COVID times where you were
changed things.
Yeah, that completely changed things. You were stuck indoors and all these different food apps came up, and the temptation was there. You couldn't get out to go to the gym anymore. Exercise, especially in the UK, exercise was limited in what you could do. And I found at that point that I really started to regain. It wasn't until relatively recently that
Can I interrupt you again? I'm really sorry about that, but I really enjoy our discussion. So when you experienced weight regain after surgery, did you experience any issues during the weight regain? Did you have any problems?
So during the weight regain, no, I didn't have any issues on that. It just gradually started to
It
go
took a period
back
of
on. It was
time.
over a
Yeah.
period of time. It wasn't a quick process. It was over a period of time that happened. Following regain, I now have issues that I'm trying to address as part of my overall journey. Recently, though, I have gone on to other pharmacotherapy treatments that are there as well. Over the last 5 months or so, I've been lucky to lose about 30 kilos on that as well. So
very
it
good.
started to go in the right direction again.
Mm-hmm. And can you remind us, please, how are you receiving this intervention, the pharmacotherapy intervention? Is it something you're having through an NHS service, because we are based in the UK? Or is it something that you sought yourself? Do you have specialist input, even if you sought yourself? Do you have multidisciplinary support? Is there a difference between the multidisciplinary support you received during surgery and during pharmacotherapy?
Yeah.
A lot of questions, sorry.
No, that's fine. So, in terms of the availability within the NHS, it is very limited. So, I am self-funding at this moment in time. The self-funded route isn't as in-depth as what it was previously through the pathways that were there. So, it is very much just down to me and the provider that I have got. They do have availability of doctors who you can message in and talk to, but it's not the same as what it was before, or the pathways that were available within the NHS.
Okay. And did the opportunity or problem during COVID, did that bring any virtual or other types of remote support for you? Did you have any opportunities to have remote support?
So
How did that work for you?
in my area, everything shut down. All the services shut down. There was nothing available at all
Everyone was looking
during
after
COVID.
COVID then,
Yeah,
yes.
yeah. Following COVID, there was online sessions that were available, but for me, that didn't suit personally. It's just not for me. I don't think it's very personable. With my weight that I've gone up to, I couldn't get scales to weigh myself, so there was no benefit to me being on that group, and I fell away from it as a result.
Thank you. For me, for my colleagues, and I'm sure for the audience, it is extremely important to hear your experience. And what I would like to know is what you have felt throughout your treatment journey has been the greatest limitation of living with obesity in your daily living. So what has been the greatest problem for you?
Yeah. So living with obesity has its challenges. As you'll all know, it's from first thing in the morning, waking up and getting out of bed with the aches and pains, and it's to even going up the stairs at the end of the kind of day. It's those still aches and pains are there. And it's not until you start to lose weight again that they
You
start to
realize
ease, and you realize that
you had a problem.
I had
There
a
was a
problem.
problem.
Yes, and it was a problem that was there.
Thank you. So that's extremely helpful. Now, I would like us to finish this discussion, because we've got more to discuss later on a positive note. So what is your hope for the people living with obesity? So what is your hope for things coming, and what would you like to see happening for people living with obesity?
So I would like to see better care for people who are living with obesity, more treatment options, more support for people who are in the exact same position as me. I also want to see a move away from the stigma that's still there. We've progressed loads over the last couple of years, but stigma is still very prevalent there as well, especially in the likes of the media, online. It's still very much there. I would really like to see a move away from that. And there is services, and there's materials that are out there that can help people do that. It's about spreading that information out to try and move away from the kind of torso photos or the photos of somebody eating a burger to reduce the stigma that's there.
Thank you. So when you say better obesity care, do you mean better education? Do you mean better, more services? Can you elaborate on a little bit on what you would prefer as better obesity care?
Yep. So it has to be a holistic approach. It has to
Yes.
have everything that's there. So it has to have the access to the support networks that are there. It
Yes.
has to be access to surgical intervention, if that's the case, or pharmaceutical intervention as well. It has to be a kind of whole system approach that's there to help support the people who are living with obesity.
That's really good to hear. Thank you. Thank you very much, Andrew. I really appreciate this. Now, I'm not going to delay a lot because we have some very interesting presentations. What I'd like to do is, first of all, thank you, because we are already getting questions, and this is very interesting, and we're really grateful for that. What I'd like to do is, I'd like to remind you that today is a special occasion. It's the World Obesity Day. We have a panel of experts, and we have a person with experience living with obesity who is also helping others, being involved in a major support group. So please use the chat function, put your questions through, put as many questions as you can. We would love to answer all your questions if we can. What I'd like to remind you is that please do not put any drug-specific questions, any drugs we have available at the moment, any drugs we might have available in the future, and please do not put any questions relating to any unlicensed obesity treatments. But if you do have questions relating to these topics, please do reach out to your local Lilly affiliates in your country. Now, the first talk is from my colleague, Thomas. Thomas is going to talk to us about the pathophysiology and epidemiology of obesity, and I'm really looking forward to that talk. Over to you, Thomas.
Thank you, Georgios, for this kind introduction. So, dear colleagues, I'm also very much looking forward to starting the three presentation with some basic information on epidemiological and pathophysiological aspects for the disease we call obesity. And I think in this audience, we all are aware of the fact that obesity is a highly prevalent, it's a highly complex, progressive, and unfortunately, and we heard the story of Andrew, it's a relapsing chronic disease state. We define obesity as an excessive body fat, and this excessive body fat can then directly impair the health of affected individuals. The World Health Organization estimated that the number of people affected by obesity are about 1 billion in 2022, most of them adult individuals. And on the right-hand side, you can see the geographical variation in obesity rates, depending on the countries. Importantly, obesity is also associated with multiple life-limiting diseases and an unacceptable high number of premature deaths. And Barbara will talk on this highly important issue in the next minutes. Of course, if a disease is that prevalent, many risk factors have been identified for obesity. And here's an overview on very few but important risk factors for developing obesity. And you can appreciate that there are some factors which we can influence by our treatment, for example, increase physical exercise. But on the other side, there are some factors which we cannot address, such as genetic factors. And most importantly, in people with obesity, there's not a single risk factor contributing to obesity alone. So there's usually more than one and often a lot of risk factors contributing to a combined risk to develop obesity. And even more importantly, these risk factors differs from patient to patient. So the patient sitting in front of me now has clearly other risk factors for his or her own obesity compared to the next patient who comes in our office in 20 minutes. Clearly, it is important to point out what are the most important and most relevant risk factors. And here we have some evidence that especially the genes can really significantly determine a person's risk to develop obesity. And evidence for this hypothesis came from twin studies back in the 90s of the last century in Sweden. And here, for example, there was a study in identical twins that were directly separated at birth. So they were raised in a completely different environment, but in a later age, their BMI was highly correlated to each other. And with this evidence and some other evidence, we estimate that around 40 to 70% of the difference in body weight between two different persons is due to the difference in genes. When obesity has developed, irrespective of the causes in a person with obesity, then we know that the adipose tissue itself, especially the adipocytes, are key drivers of obesity-related complication. So if our adipose tissue depots increase in terms of size, but also increase in terms of number of adipocytes, we store these energy also in other tissues, in ectopic tissues, such as pancreas, liver, and the heart. And here, and in the adipose tissue, these increased adipocytes contribute to complication, for instance, by producing a pro-inflammatory milieu that then in turn causes insulin resistance. And based on this hypothesis, it makes absolutely sense to promote weight loss in individuals with obesity. However, as we heard from Andrew, this is not that easy, and periods with weight loss and successful weight loss are followed by periods with a rapid weight regain. And clearly, some causes for this regain, for this yo-yo effect, need to be pointed out. And here's one very important risk factor for weight regain. It is peripheral hormones. And here you see an overview of some cytokines in our circulation that are dysregulated in patients who successfully lost weight. And these dysregulated cytokines increase the risk for body weight regain. So to summarize, unfortunately, our body has developed several compensatory mechanisms that favor weight regain after a successful weight intervention. And we need to address this in a long-term perspective in our people living with obesity. And with this, I would like to thank you for your attention and would like to hand over to Georgios. Thank you.
Thank you so much, Thomas. I think Thomas has addressed very well the pathophysiology and epidemiology of obesity topic, which is extremely important and also addresses the first of the objectives of today's webinar, which is improving our knowledge around the pathophysiology of obesity. And while our second speaker is preparing herself for a great talk around the spectrum of obesity-related complications, I'd like to grasp the opportunity and ask my colleague has one question, which is around your back alley. So would you be kind enough to remind us the updated IFSO guidelines on metabolic and bariatric surgery? Thank you.
In 2022, both IFSO and the ASMBS have revised the criteria or eligibility criteria for bariatric surgery. Prior to that, we've had criteria since many years. And in 2022, what they've decided is to drop the threshold for eligibility for bariatric surgery based on the evidence that earlier intervention when it comes to obesity is better. So rather than waiting for the medical problems to happen, you'd need to intervene sooner. So with the updated guidelines, any individual with obesity and a BMI of 30 and above and one medical problem, they need to be considered for bariatric surgery. If the BMI is 35 and above, regardless about the presence of associated medical conditions or not, they should be considered for metabolic and bariatric surgery. And as we've spoken earlier, these criteria would apply to individuals living in the Western Hemisphere, whereas for individuals from an Asian descent, we would consider a lower threshold for eligibility for bariatric surgery. And 27 is the magic number when it comes to these individuals.
Fantastic. So early intervention and personalized, ethnically sensitive recommendations. That's excellent. Thank you so much, Haz. Before I go to Barbara, one very quick comment. Thank you so much. Your questions are coming through, and that's excellent. We want this webinar to be a memorable experience for you, and we want you to find it helpful and valuable for your future clinical interaction. So we want to give it a personalized note. So please, if I can kindly ask you to put your questions through with your first name and your country, and we will make sure that we make reference to that. Barbara, over to you. Thank you so much.
Thank you, Georges, and good evening, everybody. So we've heard about the pathophysiology of obesity, and now I would like to move on to talk about the health-related complications associated with obesity. But first of all, I'd like to remind everybody that obesity can lead to reduced life expectancy. So if we take a 35-year-old person with a normal BMI, they have about an 80% chance of reaching the age of 70. Now, if we look at somebody with a BMI of 40 or above, that reduces to 50%. If we now translate that into years, life expectancy is reduced on average by about 2 to 4 years for those with a BMI of 30 to 35, and 8 to 10 years for those people with a BMI of 40 to 50, compared to people living without obesity. Not only this, there's a significant impact on mental health. And we also know that people with class 3 obesity, again, those with a BMI over 40, are almost 5 times more likely to experience an episode of major depression in the past year compared to those of average weight. So let's talk about these complications. And there are at least 200 of them, which affect multiple organs and have more than one origin. And we can broadly divide the complications into 3 categories, what are called the 3 M's, starting with metabolic effects, followed by the mechanical effects of obesity, and finally the mental health effects. So starting with metabolic first, so we know that obesity is associated with an increased prevalence of type 2 diabetes, for example, cardiovascular disease, dyslipidemia, hypertension, diastolic heart failure, myocardial infarctions. We all know that the heart plays a big part. What about the liver? Well, again, in the liver, we have metabolic dysfunction-associated fatty liver disease and steatohepatitis, as well as cirrhosis. Gallstones, infertility, many more diseases, gout and pancreatitis. On the mechanical side, we know that excessive adiposity can cause osteoarthritis. It can cause chronic back pain. It can lead to obstructive sleep apnea. In women specifically, it can cause urinary stress incontinence, especially postmenopausally. And finally, looking at psychosocial effects, we have anxiety, mood disorders, which are very common in people living with obesity, as well as the areas of stroke and dementia. Now, we mustn't forget the multiple cancers associated with obesity. And there are many named, including breast, cervical, colorectal, endometrial cancer. And I will touch upon this again. And it's really important for a patient to know that they have an increased risk for those with a BMI over 30. Now, of course, also translates into early death. And in 2019, we can report 5 million early deaths associated with complications of obesity. But let's also look at the risk associated with complications which can lead to poor health outcomes. So, for example, there is at least a 5 times greater risk of developing type 2 diabetes and sleep apnea. There is at least a 2-fold increase in the development of hypertension, and at least a 1.5 times increased risk for heart failure, asthma, osteoarthritis, chronic kidney disease. And going back to the cancer story, obesity-related cancers, depending on the type of cancer, there could be a 7-fold increased risk for that particular cancer. Now, there was a resource survey which was carried out in Europe a few years ago, which showed that approximately 3/4 of people living with obesity had at least one obesity-related complication. And the same study showed that if the BMI was above 40, i.e. class 3 obesity, they were more likely to report multiple obesity-related complications for those in lower obesity classes. Now let's go back to cancer and the risk of cancers as BMI increases. What I want to show here is basically that increased risk. So what we can see is in the light pink is BMI of less than 25. In the middle, in the basically the clean increase and colorectal kid postmenopausal news is that it can improve complications going through, and on the that we're trying to address, different ways are required to achieve improvement or remission. So there are some conditions, for example, such as dyslipidemia or hypertension, where the greater the weight loss, the greater the improvement. So even beyond 15%, we can see improvement in triglycerides, for example, or improvement in blood pressure. If we're trying to address a reduction in cardiovascular risk, then really we have to achieve at least probably 30% weight loss. If we are thinking about diabetes, we know from the direct studies that people with early diabetes can achieve remission with about 15% weight loss. Other conditions, such as osteoarthritis or sleep apnea, for example, require probably somewhere between 5 and 10% to actually translate into improvements in those conditions. Others, such as MASH, steatohepatitis, again, we're really looking beyond 25%. So when we're thinking about treatment, we need to think about what are we treating, what conditions, and this can help us with the target and the intervention. And with that, I'd like to hand back to Georgios. Thank you.
Thank you so much, Barbara. This is excellent, really. And I think you addressed the second objective of today's webinar, early intervention, very, very eloquently. Thank you. And while our third speaker, is preparing for his presentation, again, I'd like to thank you for your questions. We have questions from the UK, from India, and thank you to our colleagues from India for staying up so late to be with us. From Spain, what I would like to point out is that some of your questions relate to medications, our medications that, as I mentioned earlier, we will not be able to answer any questions relating to medications. This webinar is an obesity disease state related webinar, so please do not put any questions relating to any medications or unlicensed treatment. Please do put any questions you want relating around obesity. I'd like to ask one quick question, my colleague Thomas. So Thomas, thank you very much for your earlier presentation. What I wanted to reiterate, which I think is an important message, is what is the role of incretin hormones like GLP-1 and GIP in energy regulation and subsequently weight management? So tell us, where are they released? Where are the receptors? How do they work? Yep. Take us through that. Thank you.
Absolutely, absolutely. That is clearly a very, very important point, because there has been a long journey to identify the best hormones which affect body weight regulation. And I have provided you some different cytokines coming from different tissues. But during the last 2 decades, it turned out that especially hormones coming from our intestine, might be the best candidate for the treatment of the obesity. And here, two of those incretins, hormones coming from the intestine, are clearly some of the most attractive candidates. So this is GLP-1 and the GIP. And with regards to obesity, they both act in the brain, but also in the periphery. And for instance, they decrease the appetite, they increase the satiety, and they can delay gastric emptying, and they have further peripheral effects. So at this moment, especially these two candidates are the most attractive hormones for the treatment of obesity.
Thank you. So there's clearly a role for manipulation of these incretin hormones. Thank you so much. So I'm not going to delay any further. The next presentation is another very exciting one from Hazem, looking at obesity management practices. So this is a very practical presentation. Over to you, Haz. I look forward to your talk.
Thank you very much, Georgios. Good day, everyone. It's a pleasure to be here amongst you today on the World Obesity Day. My name is Hazem El-Momani, consultant bariatric surgeon based in Abu Dhabi, the United Arab Emirates. And my talk today is a natural continuum of what we have heard so far from our colleague. Thomas started by telling us about the pathogenesis, the genetics, and various components of obesity. Barbara went on to tell us about how our bodies are affected by obesity. And I'm here to talk to you about what is it that we're doing now to treat obesity, and how can we improve what we do to help individuals like Andrew. And unfortunately, current practice and care provided to individuals with obesity is failing low of standards. In a questionnaire involving people with obesity from 11 countries, only 54% had reported that they have had the chance to discuss their problem with their healthcare professional. And once they've had the opportunity to discuss it, only 36% were told that they have got obesity, meaning that only 36% were given a diagnosis to their illness. And of those 36%, only 21% had a follow-up related to their condition. And it's not surprisingly then that the delay from the minute of being diagnosed with obesity till receiving adequate evidence-based treatment is delayed by about 6 years globally and 9 years in the United Kingdom. And these are precious years during which complications or medical problems related to obesity would have developed, be it metabolic, mechanical, or psychological. And not only that, for those individuals who have been given the diagnosis of obesity, less than 4% are offered medical treatment to their condition. And these figures come from 8 territories within the United States of America, covering a population of over 2.2 million. So the numbers are scary. And from our experience with bariatric surgery, less than 2% of individuals who's been diagnosed with obesity are being considered for metabolic and bariatric surgery. Which makes us wonder, why is it that this is happening? Education is one of them, but amongst the leading causes of delayed in the diagnosis and provisional of evidence-based treatment is stigmatization. Healthcare professionals dealing with individuals with obesity tend to blame the patient. There's a common belief and misunderstanding that the patient is in charge of the reason that they've got obesity. This not only affects the care that we give them to treat their obesity, but it also affects the treatments that we give them for other conditions. Nearly 62% of women who have attended for their healthcare professionals have been experiencing or exposed to behavior or language that they thought victimized them or blamed them for their problem. And what we also need to keep in mind is that stigmatization is not always in words. It could be the way we set up our clinics without providing adequate furniture, smaller chairs. narrow examination trolleys, even the ambulances, the operating room, and the surgical gowns we give to our patient could stigmatize our individuals. And unless we start changing our behavior, I don't think we'll be able to offer these individuals the treatment that they're entitled to. Luckily, nowadays we've got evidence-based recommendation and guidelines about providing the adequate treatment, the tailor individualized treatment to every individual based on their grade of obesity. And what we know that for individuals with a BMI of 27 and above with associated obesity-related medical problems, we ought to consider them for pharmacotherapy. And once their BMI exceeds 30 in the presence of a medical problem, metabolic and bariatric surgery should be considered. And as mentioned earlier, if their BMI exceeds 35 in the absence of medical complications, bariatric and metabolic surgery should be considered. The cornerstone of all of these treatments is their adequate support. Conscious behavioral modification, dietary advice, maybe psychological assessments and support are important for the longevity of any treatment we offer for our individuals. And for most of us who are not familiar of how to start the conversation with our patients, the 5 A's model is something to keep in mind. Start by an open question, similar to what Andrew has mentioned with his primary healthcare professional. Andrew, would you mind if we talk about your weight today? This is an icebreaker that develops or builds a rapport with our patients. Once we've got that consent and mutual agreement to commence on the journey, we can assess the extent of the obesity and what other medical problems is related to it. Then we can advise the patient on what's the best treatment available for them. We can agree on a management plan, and then we can guide them in the right direction. The 5 A's model is proven to be effective, is easy to be applied in our day-to-day practice when dealing with our patients suffering with obesity. And once we've started the journey of treatment, these are the goals that we should be aiming to achieve. We will aim to reduce weight by reducing the amount of adipose tissue in its ectopic places that Thomas had discussed. We should try to prevent the evolution or the development of the associated medical problems. We will try to improve whatever medical problems are there. We will also try to improve the quality of life of our individuals. And most importantly, the goal of our treatment is to improve the longevity and life expectancy, a good quality of life for individuals diagnosed with obesity. And if we are to wrap things up, we can say that obesity is a complex disease. No two people with obesity have got the same problem. It's a chronic disease that cannot be treated in one visit. It's a progressive disease if left untreated and can predispose to other conditions. It is a disease with serious implications to our life expectancy, to our general health, be it physical, mental, or metabolic. Urgent, prompt, proactive, and early management is essential. Do not wait for the complications to develop. Start treatment early. We've got in our hand several safe, easy to use, and effective treatments for individuals with obesity. This brings my talk to an end. It's been a real pleasure speaking to you all, and I look forward to receiving your questions.
Thank you so much, Hazem. That was a great presentation, and what you said resonated with me. Obesity requires proactive care, and that's the third of today's webinar objectives. Thank you so much for that. Now, we are on time for our Q&A session. But before we do that, there are a couple of things I would like to do. As we prepare for the Q&A session, I'd like to ask my colleague, Professor Barbara McGowan, a question relating to pharmacotherapy. So in your extensive experience with all treatment options and specifically pharmacotherapy, what is the ideal profile of an individual who you would consider for pharmacotherapy, assuming that we were in an ideal world, and then equally in an environment like the NHS, where you practice, where there is restrictions with obesity treatment?
Thank you, Georges, for that question. So most people, I guess, who might ask for pharmacotherapy have tried other interventions and usually have failed. So, but we mustn't underestimate, of course, the lifestyle, which is always first and foremost very, very
Absolutely.
important, and
an
the
adjunct.
wraparound care as an adjunct, absolutely. I mean, if we look at the licensing of the medications, just to remind ourselves, these medications are licensed for patients with a BMI of 30 with no complications, or a BMI of 27 plus 1 complication. Now, in an ideal world, I think the sweet spot where we should be using them, I think, is probably for patients with a BMI between 27 and 35 with at least 1 complication, because that's really where we get the most for our bucks. We can intervene early, we can get remission of complications, and we can prevent complications. So I really think that early intervention is what we should be doing. Unfortunately, in a cash-strapped NHS, NICE, our National Institute of Clinical Excellence, basically suggests that we should, or recommends that we should be using them in patients with a BMI of 35 plus 1 complication, and that's just a starting point. Within that, let's take the UK, there are 4 million people that meet that criteria, and again, because we can't afford to treat 4 million people, at least with the medication, we have to restrict to use a lot more. So we have to use it for those, for example, who need to lose weight for a kidney transplant or an organ transplant or time-sensitive surgery, or patients with severe obstructive sleep apnea, or patients with raised intracranial pressure and significant headaches and reduction in quality of life. So really, the reality is that we're prescribing this medication to very, very few people. As Andrew mentioned, it's very, very difficult to get access, but we also cannot afford to not do anything, of course, because the cost of not doing anything is so much more than intervening.
Thank you. Wonderful. Thank you. So we're ready for the Q&A session. Before we start, one quick ask from you is to go through the polling question one more time. We've had the pleasure of 3 excellent presentations and Andrew's lived experience, which was invaluable. So I would like us to go through the polling question once more. And as I mentioned earlier, the options you can use as answers may vary slightly based on your location. So obesity is a chronic multifactorial disease influenced by factors beyond just diet and physical activity. What percentage of obesity can we attribute to biological factors, with the remaining percentage influenced by environmental factors? And Thomas addressed that very nicely earlier. Okay, so again, thank you very much. We have many questions, and we're going to try to get through as many as we possibly can. We have a very topical question from Dr. Dipesh Patel from the UK. And this topical question relates to the newly published Lancet Commission report. So I would like to ask the panel, what is their overall view of the new guideline? Is it in the right direction? What does the panel feel about this? So maybe we can start with Professor McGowan.
Thank you for the question. So I think the Lancet report again agrees with other obesity bodies that obesity is a chronic disease. Absolutely, we all agree with that, and it's a reminder that that's exactly right. And it is associated
adiposity-based.
An adiposity-based disease, absolutely, and there are complications associated with the disease, and also, it moves away from BMI.
Yes.
It reminds again that BMI should not be the only criteria by which we measure adiposity. So I think we're all in agreement with that. I think there are other aspects of the paper that sort of define preclinical obesity as a risk factor and clinical obesity as the disease itself. And I think there are probably some controversies around this particular area. And some of us like to think of preclinical obesity as a disease in itself, and we don't certainly wait for the complications to manifest themselves before we initiate treatment.
So overall, you think that it is a positive step forward, and there are, because it addresses obesity as an adiposity-based condition, but there are things that require more.
I think it's great that we're talking about it, and it raises a
Yes,
conversation again. And the more we talk about obesity, it's a good thing. And like I said, it's a good thing that it absolutely defines obesity as a disease.
Thank you. That's very clear.
And I
Any
think,
other views?
Fully agree.
listening to Dr. Patel's question, it is obvious from their question that the discussion had started with this commission report.
Yes.
It's making the right noise, it's getting people to talk. We've always said the BMI should not define if someone has got obesity or not. Our treatment should not be based on the BMI. Obesity is an adiposity disease. We are still waiting to hear how the other regulators and bodies will respond to this commission statement. It's definitely a move in the right direction in that the noise is there, but it's still not widely adopted. There are people, it's like Marmite. There are people who like it and people who've got their reservation, but it's definitely making the right noise.
Thank you so much. That's excellent. Thomas, did you have anything you wanted to add?
Fully agree with our two colleagues, and just emphasizing that the chronic disease state and the relevance of obesity-related complications. And I think these are the main and major aspects that cannot be repeated too less. So it must constantly be repeated.
Thank you. That's great. The next question we have is from Dr. Nemish Gandhi. And this is a question taking us back to metabolic adaptation, adaptive thermogenesis, the body's fight back response to weight loss. So specifically, Dr. Gandhi says that decreased satiety is a big problem after weight loss. And how can we address this? Can we address it, and how can we address it? So what happens during weight reduction, and does that impair efforts for sustained weight reduction? So what happens during weight loss, and how can we mitigate what happens during weight loss if we can?
Yeah.
Who would like to take that one?
So maybe I start with this. So during weight loss, we have changes in several body compartments involved in the regulation of body weight. And clearly, key areas are the brain, the reward system, the hypothalamus area, prefrontal cortex, which integrate, especially in the hypothalamus, several signals coming from visual signals to olfactory signals, but also peripheral signals. And all these kinds of signals change after weight loss. And I have presented some data on dysregulated hormones after a successful lose of body weight that reduce the satiety and by maybe manipulating on some of these hormones, and we discussed some of these in your first question, this could be an approach. However, there are several other mechanisms involved. For example, mechanisms related to adipocytes function. So there's a change in the extracellular matrix around the adipose tissue during weight loss, which also produces signals and produces a milieu that increases the possibility for body weight regain. So there are several factors contributing to the risk.
That's very interesting what you just said. I find that very interesting. So what you're saying is that adipose tissue retains obesity memory after weight regain, and there might be a cumulative effect, and this is why maybe we regain weight rapidly after weight loss.
Yeah. So the adipose tissue as the tissue shows some memory, but when we ask ourselves, what are the cell types involved in this obesity memory, if you want to name it that way, then we have some evidence from older studies that especially immune cells are involved in this obesity, and memory, here especially macrophage, that remains in our adipose tissue even after a successful weight loss.
Mm.
And last year, Matthias Flüer from our University of Leipzig also provided some evidence that the adipocytes themselves have some obesity memory, which remains in a negative way even after weight loss.
Thank you. That's excellent. I think we addressed both what happens and how we could mitigate. Please, Hazem, I think you wanted to ask. You wanted to.
What I would say
add something.
is I think this is the core of the complexity and the chronicity of obesity.
Yes.
Your body, once you've been diagnosed with it, is in favor of keeping you having it. We talked about it happening at a cellular level. We know that the newer medications could be of value, and Andrew has touched on that about strategies that he was taught through behavioral therapy. It's not an easy job. You're fighting your biology.
Yes.
It is an active process.
Losing fight.
It's not a losing fight. It's a losing fight if you don't have the right tactic and you don't have the right mindset to be prepared that this beast is there to come back. So you always have to be on the watch, and you have to actively keep on treating this condition.
And it's a biological process, and not being a weak person. This is a very, very important point.
100%.
So it's not the fault of the person living with obesity.
Thank you. It's beyond their control.
Yeah.
So that's excellent. Thank you so much, everyone. That's great. The next question is from our colleagues from Spain. So thank you to our colleagues from Spain for sending that question through. So this is a question which I think Hazem may be able to answer, and the other colleagues, of course, but I think it's more relevant for Hazem. So our colleagues from Spain are asking whether you or the panel thinks that the new IFSO guidelines and the cutoffs for offering bariatric surgery are maybe too low, and they could be overlapping with cutoffs for pharmacotherapy. So what the colleagues in Spain are saying is there a competition between the treatments? Should treatments be viewed as different, competitive treatments? Should they be viewed as adjunct? Do we have any examples from other diseases we could use when we combine treatments?
So I could see where they're coming within the question, and we get asked this a lot in our events. I'll start from the last bit of your question.
Thank you.
If you approach it as a competition, then you're not doing a good job. It's not a competition, it's a complement. It is an evolving science. We still don't know where we are heading with these new medications. When EFSO and the ASMBS set off to update their guidelines, we did not have some of the molecules we've got in our practice nowadays. When they set up to set these new guidelines, it was based on the evidence that the best outcomes happen before the comorbidities develop. When you treat people with obesity before diabetes, you reduce their lifelong likelihood of developing diabetes.
Early intervention.
Earlier intervention. And this is where it came from. It was never because, we're trying to protect our territory or protect our turf. At that point, we did not have the potent medications we've got nowadays. So the answer is no. The second is a multidisciplinary, multi-model therapy is the way forward. And if for those individuals asking the question, if we look at the recent update IFSO position statement about revisional or weight gain recurrence after bariatric surgery, they will state, consider pharmacotherapy prior on embarking on revisional surgery. So it is an all-way, multifaceted treatment, a multi-modality, multidisciplinary approach. If it's a competition, at the end, who's going to win? I'm going to win, but Andrew's going to lose. And I think it's the wrong mindset.
Thank you so much. That's excellent. We've got I think a sequel to that question from Mateusz Kamiski from Poland. Apologies to my colleague if I'm mispronouncing their name. And the question is, should pharmacotherapy be mandatory before surgery or after surgery?
We don't have enough evidence.
What is the role of pharmacotherapy before surgery? So from with your surgical hat on, and maybe I can ask my medical colleagues.
The current evidence we've got so far is for individuals with severe grades of obesity. We've got a couple of publications, case series, where they've reduced their BMI to a more acceptable BMI and safer BMI for surgery. Regarding their use in the post-operative period, we've got at least 3 systematic reviews talking about the efficacy of pharmacotherapy post-bariatric surgery. Having said that, most of these publications are based on different molecules to the one we've got nowadays. The evidence is evolving. Use it with caution. Give it to your patients to reduce their risk for surgery should they have inadequate clinical response or weight gain recurrence after the surgery, rather than putting them through a revisional surgery with higher risk of complications. Some of these molecules are quite as potent as surgery. They don't have the longevity of surgery. This is 2025. I don't know how things are going to be in 2023 or, sorry, 2035.
Yep, fair point, fair point. So I want your experience, your theater experience in that regard. So in your experience, people who have had pharmacotherapy before surgery, when you are in theater, what do you see different? Do you see anything different? Is there a benefit to your surgical plan and your surgical?
It depends on what evidence you treat. We know that the surgery is easier. Obviously, the recommendation.
Why is it easier?
Because they have lost weight. They have lost weight, and as we know from the publications and from the practice, a lot of this weight is going from the visceral fat. So it does make your surgery easier. So that's the first thing. As long as you stop the medication a week before the surgery to avoid any anesthesia complication based on the recommendation of the American Anesthesia Association, then there are no risks. Using these medications does not delay them having the surgery. In the past, we used to, for example, put them on a special diet or put a gastric balloon in. But in that case, you're delaying the surgery till after the balloon is out, whereas now we don't need to do that. Post-surgery, this is where we're seeing the biggest advantage, because you probably know the best operation is your first operation. The outcome from a revisional surgery is usually not as pronounced as the first one. And nowadays, we're seeing comparable results with these medications compared to a redo operation, for example. Some of my patients that I've operated on 5 years ago have had a sleeve, for example. They come back, their weight had come back. I give them a medicine and I tell them, look, this is a sleeve in a box. It gives you a similar feeling to a sleeve. You're not as hungry. When you eat, you don't eat as much and you feel full quicker. And we can avoid them having an operation that carries higher risks.
Thank you. Any thoughts from my medical colleagues before, after?
Very similar. I think we have to individualize treatment, so it's definitely not a must before or after.
Yes.
Some patients absolutely benefit from losing weight for all the reasons that you've described. Some people would like to try it before surgery, in a sense, to see, let me see how I do.
They're not ready.
They're not ready. And before, we didn't have any choice when we had bariatric surgery or lifestyle. Now we do have these medications. So I do think that some people actually do very well and then don't go ahead with the surgery. And equally, post-surgery, we know that obesity is a chronic relapsing disease.
Mm-hmm.
We've heard from Andrew about weight regain, and therefore I think these agents play a really important role because, as you say, revisional surgery is hard. It doesn't work most of the time, and I think we're going to be using these agents more and more for post-bariatric.
Thank you, Barbara. Thomas, did you want to add anything?
Maybe I can add two more points on this issue. So I think what is very important to note in this context, from my perspective, is that we need multidisciplinary teams to individualize the treatment options that are available, and most importantly, we need to include the patient's perspective in our decisions. So I think that is clearly an extremely important point, because not any therapeutical approach will be successful without having the patient on board of our combined ship, and we navigate through the course of obesity treatment together.
Okay. Thank you. Thank you very much, Thomas. I'm going to mix the questions a little bit. So we have a question from Rita Sulkaite from Lithuania. Thank you. So I'm going to ask Andrew first. So Andrew, I want you to reflect on the psychological and other assessments you had around a surgical treatment. Do you feel that that helped you changing some of the habits and behaviors?
Absolutely. It really did help. It gave me the tools that I could then implement myself along the journey, and still can now as well, to make sure that the emotional eating doesn't come back in, I've got tools that I can use to combat that. The same with the binge eating disorders as well. You can implement those same tools. So 100%, it's benefited me greatly to have that support.
Thank you. So Rita's question referred to things that patients may not know that they are overeating, they may not realize, and that may be because of a lack of education. So as you say, educating on healthy behaviors and assessment before any intervention and optimizing these makes a lot of sense and would help Rita with some of the outcomes she's mentioning. Excellent. So we have a very interesting question. I find it very interesting from Rose. And Rose is asking, is there a relationship between obesity and other behaviors like smoking, like drinking alcohol? So is obesity linked to some addiction behaviors? Who would like to? And what is the potential mechanism or cause for that? And do we know anything around the field that's happening at the moment? Who would like to answer that one?
I'm going to give it to Thomas first.
Yeah, of course, when the reward system is involved in control of food intake, then the system works in the same way like it works for alcohol intake, smoking, etc.
Yes.
So the same neurotransmitters are involved in the regulation. So we can say some pathomechanisms are similar in alcohol intake and alcohol addiction and obesity. And however, we see obesity as a complex disease. Obesity is not a brain disease. Obesity is a multisystemic disease for peripheral, but also brain aspects. And this, I think, clearly separates obesity from alcohol addiction.
That's really good. And I'd like to continue with Thomas for 1 minute, and then everyone can add on. So Thomas, in your experience, when you've treated someone with pharmacotherapy or someone you've seen after surgery, have they mentioned any change to their behavior?
Good point, because this question goes back to the surgical perspective, but I would like to start.
And the medical.
So with internal medicine. So in my own experience, it is the opposite of the findings we have for some bariatric studies. So I found that several individuals on pharmacotherapy for obesity report that they have less alcohol intake afterwards. They don't have a motivation to consume alcohol and to smoke. So this I found very, very interesting. There are some phase 2 studies investigating these kind of treatments, also for these kind of addiction issues. But we will have some answers in the future.
Goes back to the same circuitry you mentioned, and the same pathways and addiction reward centers in the brain. Haz and then Barbara.
I think what Thomas has said, it is a complex pathway. The way our food is being made and designed nowadays is meant to trigger the hedonic system, where you eat for pleasure rather than to stay alive. There is the concept of addiction shift following bariatric surgery. So a lot of people are addicted to food. It's their comfort, be it their treatment for depression, for stress, for whatever. Once you take that away from them, they tend to shift that addiction to something else, be it alcohol or tobacco. Then there is the food preference, which we see after bariatric surgery. A lot of people would start hating food that they used to love before, and said the taste of food changes, and the same goes for tobacco and alcohol.
We know there are receptors in taste buds that may affect that.
And then you've got the newer pharmacotherapy and some earlier publications talking about the reduced use or reliance on alcohol and tobacco.
Yes.
I think there is no straightforward answer. It's a complex thing.
Absolutely.
There is an overlap. And this is something to be aware of in individuals with obesity. And I always tell people, why do you eat? If you're eating it for a hobby, I'm taking this away from you with an operation. What are you going to do after? Because some of these people end up looking for some other things to treat them. And unless we treat them psychologically, we probably have only treated their eating, but we have not treated the core of their problem or the
Thank
cause
you.
of
I
their
really
problem.
love the discussion. It's very active. Please, Barbara, I want to hear your expertise and your opinion on this. I'm sure you've had a lot of
Yes, I mean, I agree with
cases.
my colleagues. Obviously the difference between eating or food and alcohol and smoking is that we need food to survive, whereas we certainly don't need smoking or alcohol. But there is no doubt that with the new pharmacotherapies that we're using, we are switching off not only the food noises, but also people say, I don't want to smoke anymore, and I don't want to drink anymore. It is quite extraordinary. So I think they're actually teaching us quite a lot about, these addictive mechanisms and hedonic areas in the brain, and they seem to be very powerful.
The books into practice.
Yes.
Definitely.
Thank you. I'm really grateful. We've got so many questions. We don't have a lot of time. I want us to go through as many as we possibly can. So the next question is from Dr. Nemis Gandhi from India. Again, very grateful for staying up so late for this webinar. BMI is enough to diagnose obesity, to use as a treatment to predict response? Should we be using other criteria? And a very specific point is many patients in India have thin extremities, but adipose tissue around the waist. So who would like to take that one? Barbara?
I can kick off. So I think we've all said many times that, of course, BMI is very good at population level, but not at individual level. So we know that most athletes will have a BMI over 30. They don't have excess adiposity. They're just very muscular. So it's a starting point, but we need additional measures. And what are those additional measures? Well, really, whatever you can do in the clinical setting.
Give us some examples, please.
First of all, measuring waist circumference is very good as a measure of sort of, I guess, visceral adiposity. We use a waist to height ratio, which is indeed has been advocated by EASO, the European Association for the Study of Obesity, and a ratio waist to height of over 0.5 is kind of, it's a signal that actually metabolically things are not going in the right direction. So I think that's very useful. And the reason we use the waist to height ratio is because it correlates very well with increased cardiovascular risk if we look at the evidence. So I think that's something that we can do quite quickly and easily in the clinic. I mean, obviously, if you're in a setting where you can use bioimpedance machines, you can use DEXA machines, I mean, that's all great. But actually, in practice, I think just a simple waist circumference and a height is enough.
Back to the basic clinical tools. Yes,
Absolutely.
please.
And if we just, to go back to what we said earlier, for individuals from an Asian descent,
very important.
The BMI it tends to be lower than the Western population. So 30 would be a cutoff for someone in the UK, for someone in India.
Ethnically sensitive.
Correct. It could be 27.
Absolutely. We have to make adjustments.
And we know this for a fact. We've got a lot of publications from that part of the world about operating on individuals with BMI less than 30, because they do have quite severe metabolic disease despite them having a lower BMI.
And equally, when we talk about pharmacotherapy, when we said BMI of 30, no complications, or 27 plus 1, we then reduce all of that by 2.5.
Correct.
For those patients from Southeast.
Excellent comment. Thank you. So apologies, Thomas. I'm not going to ask you this question, but I'm going to ask you the next question because you spoke about the pathophysiology and epidemiology of obesity. So we have another question from Dr. Deepas Patel from the UK. And our colleague is asking, how will the numbers of people developing complications of obesity change over the next 2 decades? Is it going to go up? Is it going to go down? I think we today have the World Obesity Atlas published. So would you like to comment on that, please?
Yeah. So, of course, we just can speculate on the numbers in the future. And we have several candidates on the horizon that can pharmacologically address the disease obesity. So I think we are just at the beginning of this journey of a medical treatment-based therapy of obesity. If we are able to utilize these kind of options, then we might limit the increase in obesity rates. However, I'm a bit pessimistic for the global perspective on the...
For good reason as well, I think.
Yeah.
Barbara mentioned.
availability of these kind
was
of
receiving treatment from those eligible for treatment.
Absolutely. Yeah. And I'm a bit pessimistic whether we can achieve this on a worldwide perspective, in a global perspective.
Thank you, Barbara. Please,
Can I
and
add to
mention
that?
about the World Obesity Atlas very briefly that was published today for the awareness of our colleagues. They can go back.
So
to
I've been here all day, so I've not had a chance to look at it. But
No,
certainly, what we do have, we have 1 billion people living with obesity around the world, and if we just focus on the UK, just because I'm more familiar with the data,
Yes,
it
please.
is costing the UK, the UK economy, 98 billion pounds
Wow.
per year. Okay, so this is like the same as 4% of our GDP.
Yeah.
So we cannot afford just to sit here and do nothing. We have to speak to multiple stakeholders. We have to engage with government. We have to make sure that we have effective new treatments, effective pathways, a whole systems approach to the treatment of obesity. And of course, we should be starting in perhaps in developed countries. We should be leading the way. I am hopeful, actually, for the rest of the world. I'm much more hopeful. I think we will have newer interventions, probably oral interventions, more affordable interventions. And I'm really hoping that over the next 10 years, there's going to be a shift in paradigm in obesity.
I love the positive note.
Yeah.
I love the hope. That's great.
Same for me. So we have to do this webinar in 10 years.
Yes. We can.
100%.
I'll hold you to
I
that.
like
that.
I'll hold you to that. Okay. So we've got loads more questions. Thank you so much for that. So I have a surgical question, but I want Hazem to answer on the surgical complications, perhaps, component, and I want Barbara to answer on the pathophysiological. Why is it that many patients after surgery, metabolic surgery, weight regain? So maybe you can tell us surgical techniques and complications, pouch, etc. That could, for example,
This is a seminar on its own.
we don't.
have
We
much
really
time.
appreciate the
There are
seminar.
various factors,
but-
factors related to the surgery, factors related to the patient, and factors that we have no idea what it is.
Yes.
Our understanding of obesity is evolving.
Let's talk about the surgical, please,
surgical
and then
side.
patient and
Fair enough.
medical
So,
for Barbara.
Let's break it down per procedure. So for people who've had a gastric sleeve, for example,
Okay.
what we know is the sleeve does dilate over time, or sometimes we don't do a tight enough sleeve, or patients
Stretches back.
not all the way, but it does
Yeah.
increase, or people developing unhealthy behavior. They shift into being sweet eaters. They melt the sweets in their mouth and it goes down. And then when it comes to the bypass, they talk about dilatation of the gastrojejunostomy, so that resistance is no longer there. Then you've got the adaptation in the bowel. And this is
Symphysis.
yeah. And then the bowel will adapt, and they talk about further shortening the bowel, distalization of uranostomoses. I wish I've got a one answer. This is the title of one of my talks in the conferences, that it could take you
And
half
I
an
didn't
hour
know that before
to
I
talk
asked
about
you.
it.
I
No,
didn't know that.
no.
So there's surgical reasons for weight regain after surgery,
Agree.
and then there is
Patients-related
yes,
factors.
behavioral, and maybe something relating to metabolic adaptation, to
Yeah.
weight set point, to the brain.
Absolutely.
So Barbara, please.
I mean, we've talked about obesity as a chronic disease. We know some of the mechanisms that take place post-bariatric surgery: changes in gut hormones, changes in bile acids, changes in microbiota. Lots of these changes are positive, of course, but of course, we're still in an environment which hasn't changed. And so we go back to our biology, our gene, and that sort of set point, and perhaps memory,
of the
the
facts, yeah.
memory. We unfortunately, we survive by protecting our fat
Yep,
mass, our body
of course.
mass, and really over time, slowly we do tend to regain. It's a natural process, and that's why we get weight
Yeah.
regain over and above the surgical issues that you've mentioned.
Our bodies evolved to keep us alive.
Correct.
Yep.
The body will find a way to
Fight
get
back.
its way back.
Yeah. Thank you. Thomas, please.
And there's some healthcare system related issues. And I think, Andrew, you told us that after 24 months after surgery, the system just stopped.
Yes.
Charged.
And
yes.
there's absolutely no rationale to stop treatment for
Great comment.
chronic lifelong disease. So you would not stop antihypertensive treatment in your mother or your father being on antihypertensive drugs after 12 months. no one would ever think of this. So it's I think several components involved in this potential weight regain.
Thank
And
you
can
so
I
much.
just
So
mention something
I
quickly?
wanted to ask Andrew very quickly, if that's okay, and then I can come back to you. So I really liked what Thomas said. Obesity is a chronic relapsing disease requiring lifelong management and treatment. And I think you mentioned earlier that this was your experience as well. So you had weight regain as soon as you got discharged, or after you got discharged from your service?
That's correct. Yes. So I started gaining weight after I was discharged from the original service that I was there. And although the weight management service was still there, you could be re-referred back onto it, but they didn't know how to deal with somebody who had already had weight loss surgery. It was all set up to deal with people who were pre-surgical, who could go through the process that was there, and then maybe have a surgery at the end of it. They weren't set up to deal with people who'd already gone through that pathway. They didn't know what to do.
Thank you. Haz, please.
It
coming
was
back to
just
you.
a note to our audience, and we were talking earlier about the stigma. The language that we use when we are addressing individuals who are trying to lose weight is important as well. We don't say failure to lose weight. It's called inadequate clinical response. It's not a failure. It's like you've got hypertension, I give you a beta blocker. It doesn't respond. You didn't fail. The treatment didn't work. Let's try. So you got a suboptimal response. And this is something important. And the other term that we use often nowadays in our meetings is we don't say weight regain, we said recurrent weight gain. And I think these terminologies, you're taking away the blame. And
Very important.
you're not addressing the person, you're talking about the disease itself. And
Thank you.
I would encourage the audience to familiarize themselves with these terminologies.
Thank you. Can you very briefly, before we went for this session, you showed me who World Health Organization response and message for today, for World Obesity Day, and the focus was around stigma. Would you like to relay the message for the audience, please?
Yeah, social media was, as you know, prolific today about World Obesity Day. And I think the World Health Organization, for the first time, are talking about obesity and the stigma related to the disease. And this is an important paradigm shift. Unless the reason people with hypertension do not get denied treatment after 2 years because they're sick. And I think individuals with obesity are sick and they need to be treated in a similar sort of way.
Thank you. Barbara, if I may ask you, so weight reduction is associated with lean mass loss, muscle mass loss. What happens when we lose muscle mass? Is maintaining muscle mass important? What happens maybe both mechanically and metabolically, because muscle mass is, an important organ when it comes to insulin sensitivity. And what can we do to mitigate muscle mass loss during weight reduction interventions?
So that's a really important question, especially, I guess, as some of the new pharmacotherapies are quite potent in terms of weight loss. What we do know is that usually there's a sort of 3-to-1 ratio in terms of the amount of fat. So 3 times fat mass loss to 1 of the lean mass. So there's a relative sort of preservation of body composition. But of course, we need to individualize the treatment and see who's in front of us. So if we have a frail elderly person, losing lean muscle is an issue. We need to intervene with perhaps obviously slower weight loss that can try and preserve that. And we need to absolutely make sure that there is physical activity to preserve muscle mass. Otherwise, we do run into trouble. There's frailty, there's sarcopenia. This can have an impairment in quality of life and also activity of daily living. So, ensuring that there is plenty of muscle is important. We therefore also need to educate with regards to the diet, ensure there is enough protein in the diet. We can't make protein ourselves. So we need to ensure that that is part of the intervention and prioritize high protein, high vegetable food, and ensuring that nutrition is also adequate in our intervention.
Thank you. Do you have any practical hints about the proportion of protein with meals after weight reduction? How much protein should be what grams of protein per meals would
I sort of tend
need
to look at the bariatric example, at least 60 grams of protein, in your meal. Maybe Andrew, you probably have more experience, but yeah, about 60 grams of protein, I would say, at the very least.
Thank you.
Pharmacotherapy has taken us clinicians by surprise because of the potency and the wide adaptation of the use of these medications. And this is why such a topic became so relevant. In bariatric surgery, we didn't used to discuss it as much because the access to the therapy was quite limited and the uptake was limited. But nowadays, everyone is taking these medications. How many patients in the UK are on it now?
About 1 million people.
And how many has had surgery?
5,000 a year,
5,000.
yeah.
And this is why it becomes an issue. Diet is important. Physical activity is important. We don't have solid evidence. We copy what we do, or we used to do with our bariatric surgery to our patients or pharmacotherapy.
Thank you.
However, it's
Please,
important
Thomas.
that we clearly state that pharmacotherapy is an add-on therapy to a lifestyle treatment,
Yes,
which
as an adjunct.
comprises of a dietary advice and a continuous dietary counseling. So we need to continue this treatment and do not only provide pharmacotherapy.
Thank you so much, Thomas. If I may stay with you, we have a colleague who is asking a question. I think it's from the UK, who does not have psychology support, which Andrew mentioned is extremely useful and important. In your experience, if there is no service, are there any tools, any questionnaires, any other tools that you would recommend to help screen? And perhaps others can mention what happens in the UK. Screening tools,
so there are
phone
some
call services.
So there are some questionnaires available also through apps. In Germany, we have now licensed obesity apps, which are especially made for this kind of situation where there's no service available in the more rural parts. So the primary care physician can prescribe these obesity apps on a prescription, and they can then download these apps, screen for these kind of aspects, and then try to seek the medical advice, especially for those who were positive in the screening.
Thank you. Barbara, any tools, services?
Again, well, we certainly in our service we use there's lots of anxiety, depression scores, binge eating scores, and a number.
Can you mention any tools, any score questionnaires, perhaps, or other, or please. HADS, or for example.
Well, yes, there's a lot of them out there. As SF36, there's a number of them.
Anxiety and depression,
which test for anxiety and depression. They've been, they're good scores. But of course, if you don't have a psychologist, then you need to signpost people to the right services. You need to pick up some patients can also be suicidal as well, and that that needs to be managed and picked up and signposted to the right place. Yeah.
Thank you. Thank you.
Andrew could probably guide us on a lot of websites and support groups online that could be of help.
They're everywhere. I think every country
is
different. Every country has got the groups that are out there. So signposting these groups as well. So it may not be the clinical support that's there, but there's peer-to-peer support that is available.
Thank you. Thank you so much. So we have been through many questions. We have not been able to go through all questions, and I'm really grateful because we've had loads of questions. What I would like to do is I would like to part with a message. So the message from today's webinar is that obesity is a chronic, complex, relapsing disease that is beyond the person's control, driven by biology. It requires early intervention to prevent the development of complications, downstage existing complications, prolonged life expectancy, downstage obesity per se, and requires proactive care. With that, I would like to thank our experts, our medics, our surgeon, and especially Andrew, who has been with us today and sharing his experience. And I would like to thank you all for staying with us until late. Thank you very much indeed.